Hello, everyone, and welcome to today's training on Arkansas's REAP, Concussion Management Protocols. We appreciate you joining us today. Today's training is being recorded for others to view as time allows and for your reference as well. I am Haley Cushion with NASHA, the National Association of State Head Injury Administrators, and Arkansas has partnered with us to bring this training to you. If you have questions during our presentation, please ask them in the questions area in your attendee panel. A certificate of attendance will be sent through email after today's presentation. And this session's recording will be placed on the web at arbraininjury.org. That's arbraininjury.org, as well as the UAMS site. The handouts for today are located in the side panel and will also be on arbraininjury.org. At this time, I'd like to introduce Amy Goddard. She is the Related Services Coordinator and Brain Injury Specialist for the Office of Special Education at the Arkansas Division of Elementary and Secondary Education. Amy?
All right. Hi, everyone, and welcome to the fourth of our webinar series on REAP. We are glad that you're here on this hot Arkansas summer day, almost summer day. And it is my pleasure to introduce Dr. Karen McAvoy. She is a dually credentialed clinical and school psychologist. She's practiced as a pediatric psychologist at Seattle and Denver Children's Hospitals and as the director of the Center for Concussion with Rocky Mountain Hospital for Children. She also practiced as a school psychologist for 20 years as coordinator of mental health, coordinator of manifestation determinations, and coordinator of the brain injury team at Cherry Creek School District. After 20 years on the front lines in a school district, Dr. McAvoy then served as consultant for an additional 10 years to the Colorado Department of Education, providing trainings to multidisciplinary school teams across the state of Colorado on the impact of brain injury and neurodiversity on learning and behavior. Dr. McAvoy is the author of REAP, which stands for Remove and Reduce, Educate, Adjust, Accommodate, and Pace, a community-based interdisciplinary team approach to concussion management that's been customized in over 12 states. She's also the co-founder and owner of GetSchooledOnConcussions.com, a website and training curriculum empowering educators to oversee and direct return-to-learn efforts for students with concussion as they return to school. Dr. McAvoy continues to keep a foot in each world of medicine and education. Half-time, she provides assessments and treatment and consultation to adults and children suffering from mild, moderate, and severe brain injuries at the ASHA Brain Injury Clinic in Fort Collins, Colorado. The other half of her time is spent routinely traveling the country, providing training to schools on return to learn following brain injury. Dr. McAvoy, I turn it over to you.
All right, thank you so much, Amy. I hope you can hear me, and I will put my video on as well. So thank you so much to Arkansas for bringing in REAP and sponsoring all of these trainings, which we've done, like Amy said, over the past 4 months. We've done one per month in different categories, and today we're going to be talking about REAP as it applies to the athletic trainer, to the coach, to the school nurse, and it's our last training of 4. So I'm a little sad that that we won't be doing this again next month, but we'll figure out some other ways to keep in touch with our colleagues there in Arkansas. And I thank NASHA for pulling this together and all of the support in getting REAP in so many different states and getting so many trainings up and around. So it's my pleasure to be here today. I am going to talk about concussion management from the perspective of the team, the REAP team that is known as the light blue team, or the coach, athletic trainer, and the physical school team. So I'm going to jump right in, and hopefully we'll have some time for questions at the end. So be thinking of your questions, and we'll try to customize that at the end. So of course we're starting from the perspective of concussion management, where it started. It started in early 2009 or so regarding return to play. And if you are a coach or an athletic trainer, you know that it came from the world of sports, where we started to look at the number of students who were having serious catastrophic brain injury issues post any kind of a hit to the head while they were playing sports. And so across all of the 50 states and the District of Columbia, all states moved forward with return to play or return to sport legislation. And you can see here that the tenets in each state, as you probably know in your own state, focus on, first of all, education to some stakeholders, and that's almost always coaches, but sometimes it also includes students, it includes parents, it includes teachers. Removal of play for the athlete if there's a concern of a concussion, and then return to play under guidance from some kind of a healthcare provider, and that will vary state by state as well. So I'm going to show you how I got involved in all of this by showing you a video of what happened here in Colorado in 2004.
From Colorado's high-definition news leader, this is 9 News at 10.
For many, football season is just the best time of the year. They feel that there's virtually nothing that beats the excitement of a high school game. But with every sport, there is also the risk of injury. Recently, there's been an effort to educate athletes about concussion. Tonight, the story of a young man with second impact syndrome. That's when a concussion hasn't healed and an athlete suffers a second concussion. 9 News reporter Kim Christensen tells us about what happened 6 years ago today.
If there's an off-Broadway show in football, this is it. A stage that beckons players with big dreams.
He put his heart into it. He really, it was important to him to do well and to give it everything.
Even as a young boy, Jake Snakenberg knew he was going to get here, and then some.
Jake would have loved to play in the NFL. Would have been a dream. It was a dream.
As a freshman at Grandview High School, Jake took the stage and left it just briefly.
Didn't really complain about hitting his head or anything like that, or seeing stars, none of that, just tingly hands, but it scared him.
Out for a week, Jake was cleared to play again, his family in the stands.
I mean, there wasn't during the game any significant hit that you would go, wow, you know, that's a bell ringer or something like that. Then he went to line up and went down. He turned to come to the sideline and went down again.
The paramedics came next, then a helicopter. At Swedish Medical Center, a neurosurgeon talked to his mom.
They were trying to, they were doing everything, and he didn't think that Jake would ever play football again. I thought, okay, that'll be hard for him, but that's okay. I'm okay with that. But then it followed with, if he survives.
Jake never woke up.
It's a game. You're playing a game. And you just never, like I said, you can't anticipate that. You just never, in your wildest dreams, expect to not come home from a football game with your son.
You don't think that this is going to happen in your community. And it was ironic that we were the school that was actually doing a study when this happened.
Many of those at Jake's funeral had just joined a 3-year CDC study looking into the impact of concussions on young athletes.
We did not know he had a concussion. We were not involved in managing that concussion.
6 years later, the Grandview community is learning about the REAP project.
The more eyes you have on a concussion, the better chance you're not going to miss something that's serious. In the first year,
Karen McAvoy used to be the school psychologist. Now she's the director of the Center for Concussion. She helps train coaches, players, and parents about REAP, which stands for Reduce, Educate, Accommodate, and PACE.
What REAP is about is immediately assess, immediately identify the concussion so that you can intervene right in those first 3 weeks.
A plan to prevent brain injury and even death. One written with Jake in mind.
Jake had such a big heart and was such a good kid, and he would really want to make sure something good happened out of this.
That is the legacy that Jake has left in the area of concussion.
The legacy built on the dreams of a football player.
It's nice to not have him forgotten.
One eager to join the big show. Kim Christensen, 9 News.
A footnote, the education and awareness efforts of the Center for Concussion is for
You'll have to unmute Dr. McAvoy.
There we go. Okay, now can you hear me?
We can, thank you.
Great, thank you. Okay, so that's how I got involved in this world of concussion management. I just happened to be the psychologist at this high school when this happened to Jake. However, I was already dabbling in looking at concussion management using the impact test in the high school that I was at. We just baselined our first group of football players, and 2 weeks later we lost Jake. So if you all have gone through a situation like that in your school, in your state, you know that every state has now put forward some kind of return to play legislation so that we don't have this happen again. And as you know, with second impact syndrome, that is a phenomenon where the student has had one concussion and then takes another hit to the head before fully being recovered from that, is still symptomatic. And with that second hit to the head, they have the catastrophic events of either permanent brain damage or, in the case of Jake, with death. And you know that that is something that we were not seeing in adult athletes. We were seeing this in adolescents. So we all then worked very quickly to come together to try to do something to support our students. And in Arkansas, these are your guidelines that you, I'm sure, are aware of. You have the same kind of tenets of some training to some stakeholders. And in your state, you even have training or some information that needs to be signed by the athlete and the guardian. A removal from play if there's a suspicion of a concussion, and then return to play under medical guidance. So those are the same tenets that we have in almost all of the states. And that's what really led to writing REAP, which, as Amy pointed out, is a community-based interdisciplinary team approach to concussion management that stands for Remove, Reduce, Educate, Adjust, Accommodate, and PACE. And it really covers 4 teams, and I'll go into that in more detail. If you are looking for all the states that have customized REAP, you can go to reapconcussion.com and you can download REAP from all the states that have currently customized. But you can see here, this is your Arkansas version of it, and as we go through the rest of the training, I will be showing you pages from this book that you can be using or sharing with parents or sharing with your schools to make sure we are all on the same page with concussion management. So let's just start with the definition of a concussion. As you know, it is a very complex cellular injury that does not result in structural damage as in something that you could see on a CAT scan or an MRI. It is a cellular injury, and so it results in functional impacts. And that would mean that we would never see a cellular injury on a CAT scan or an MRI, but we can see that there are functional impacts in signs and symptoms, and I'll show you those in a minute. So anything, even a jolt to the head or a hit directly to the head, or a jolt of the body, which shakes the brain, can result in a sign or a symptom, and that is by definition a concussion. The signs and symptoms are these listed here. They fall in 4 categories. We're very comfortable talking about the physical signs and symptoms. Those would be the headache, and headache is the #1 symptom. But that would also be the nausea, the dizziness, sensitivity to light and to noise. We don't talk as much about the cognitive impacts, but as you know, these student athletes are all students first, and so therefore they often report that they have difficulty concentrating or remembering or learning new material. They also will report that they have more emotional outbursts, they're sadder, they're more anxious, and parents can confirm that. And so there are the emotional symptoms that tend to flare with a concussion. And then finally, sleep and energy. These kids feel very fatigued, they're very drowsy, they feel like they can't get enough sleep, and even when they do, it's not very restorative. So the sign would be what you would see. Perhaps they're asking the same question over and over. A symptom would be what they report to you. So if you have a student who has a concussion, you're going to want to make sure that you are looking for the signs as well as the symptoms, because if they're not even aware of their symptoms, you might notice that they don't seem themselves based upon the signs that you are observing. And while we know that concussions happen in sports, and as I said, this is where this all started from, and you can see that football, of course, generally is the highest number of concussions. we as educators are very concerned about the number of concussions that are happening now in our students that are not athletes. The Brain Steps program out of Pennsylvania has been monitoring the number of concussions in their schools across the state for the past 11 or 12 years. And when you look at the number of concussions that happen in a school that are from sports versus non-sports mechanisms, it's about 50-50 now. So if you are just looking at information that's coming from an emergency room where generally athletes go when they have a concussion, you're going to miss about half of the number of concussions. The other students who are having concussions from falls or motor vehicle accidents or assaults and are not required to see a medical doctor, although it is recommended, but some of those students do not go to an emergency room or follow up with their pediatrician. Those students are also needing the same kind of support in your schools as the athletes, and that's about 50-50 at this point. So all students must return to learn, even if they don't return to play. There's some interesting data on athletes, though, in terms of concussions. Out of this study right here. And because we're talking primarily to athletic trainers and coaches and school nurses today, I wanted to share this information with you because this is right up your alley. The interesting trends and statistics for your group that are managing more of the physical side comes from the high school Rio data. Many athletic trainers are part of that group. And you can see that there's a higher number of concussions in competition than in practice. There's a higher number in regular season than in preseason. If you look at the number of concussions in competition versus practice, you can see that the highest rate of concussions is still happening in boys football, but in competition, it's followed by girls soccer and boys hockey. In practice, it's followed by cheerleading. And the interesting thing about this is that they found that cheerleading was the only activity where there were higher numbers of concussion in practice than in competition, and that's because of where cheerleaders practice. They often practice in the gym, they practice in the parking lots, and not in areas where they have the same kind of support and cushy foam to fall on. And so there was a significantly high number of concussions in cheerleading because of where they were practicing, and that now that data has now been shared, and we're taking better care of our cheerleaders. If you look at the statistics of sports that have both boys and girls in them, the concussion rate is higher in girls than in boys, and there's also a higher rate of concussions later in the competition than there is earlier. There's not a high number of concussions in warm-ups, except in girls volleyball and softball. And you can also see that the highest number of concussions are coming from player-to-player contact, and then player to surface, and then player to equipment, such as a bat or a field hockey stick. Overall, the rates of recurrent concussions have gone down with the years, which means that we are doing a better job of education and helping our schools and our teams understand that once you've had one concussion, we need to be very careful about having further concussions. And so that is definitely progress. As you know, most of our guidance comes from the consensus statements, which now there have been 5 of them. We are a little bit stuck on the 5th one, which came out in 2016, the Berlin guidelines. We were due for a new set of consensus guidelines in 2020 in Paris. That got moved to 2021 because of COVID, and that got moved again to 2022, and that will be in Amsterdam. So look for new guidance to come in 2022, or roughly the early 2023 when that gets published. What has all this research shown us? It has shown us that the one non-negotiable or black and white recommendation with a concussion is that you cannot hit your head again while you are still symptomatic from a concussion. But shades of gray would be that you can go to school, you can go to work, you can do some social activities. You just want to do everything in smaller amounts so that you are not provoking a lot of symptoms. And that the data suggests that we need to wait for about up to 28 days for typical recovery of a concussion. About 70% of students between the ages of 5 and 18 will get better between 1 and 28 days. So that's the time frame we're looking at. What tends to lead to longer recovery? These are the items by research that have shown that predict a longer recovery: a history of headaches or migraine headaches in the family, past concussions, a history of mental health problems has risen to a level of concern where we need to watch that, and that girls do take longer to resolve than boys. No longer do we worry about learning issues and attentional issues as a predictor of longer recovery, but anything that's a bit of a weakness will be exacerbated or amplified during a concussion. And so if the student's prone to motion sickness or sleep disturbances or learning or attentional issues, those can flare while they are recovering from a new concussion. And as you know, many of our students, not many, but some of our students need some rehabilitation. And that would be in the area of ocular motor issues, that's the eye tracking concerns, the inner ear, which is the vestibular system. And then sometimes they need some manual physical therapy for the headaches or for the cervicogenic kinds of issues. And then, of course, some understanding about sleep and good mood regulation, etc. So the newest areas really for concussion management is in rehab, which is occupational therapy and vestibular physical therapy. All right, so now that we've set the groundwork for concussion management and all of the new data, let's go into REAP and see how that directs the management in our schools. So as we said, REAP stands for remove and reduce. So remove physical activity, reduce academic and social stimulation. Educate, that means let the symptoms educate you about where you are in recovery from a concussion. Adjust and accommodate the home, the school, and the social stimulation. And eventually, when the time is right, we are going to pace the student back through the graduated return to play steps, back to physical activity, and then into clearance. So REAP is an interdisciplinary team approach. It is a great place to get your entire team and your community together because it's a great jumping off point that identifies that everybody has a role in concussion management. And it outlines what the roles are so that we all can know what each other is doing, and also know that we have different times when we are involved in our part of concussion management. It does cover return to play and return to learn to some degree. It's color coded, and so I will walk through those different colors with you. The 4 different teams that we have identified that need to be involved in concussion management so that we don't miss these cases and have a catastrophic event of second impact syndrome again is that we need to have the family involved, we need to have the medical team involved, so that's the orange team and then the green team, and then the school needs to have 2 teams. That's the blue team. The school physical team is the light blue team, the school academic team is the dark blue team. And those 2 need to be working together. So if you are a school nurse, you could fall either on the light blue or the dark blue team, or both. If you are a school athletic trainer or a coach, you're most likely in the light blue team. If you are a teacher and a coach or an athletic trainer, you're going to fall in both teams so that you can see what parts you are working on when. So in the beginning of a concussion, it could be the family who's recognizing this and identifying it. It could be you as the coach or the athletic trainer, or if it's an injury that happens in the middle of the day, it could be the school nurse. And eventually it makes its way to the healthcare provider. So in the beginning of a concussion, those 3 teams are involved. So the remove and the reduce page is all about how do we all work together to remove the most serious concern, which is preventing that student from getting another hit to the head while they are still symptomatic. That is the story of Jake right there that you just saw the news clipping on. This is the story of a student in your state that also had a very catastrophic outcome after a concussion and sports injury. This is what the school physical team would do. So if you're a coach or an athletic trainer, you might be the first one to see the concussion and to suspect it, remove them from play, don't allow them to return to play again. If they might come to you as the athletic trainer or the coach to check in on symptoms daily. You might be involved in doing the weekly neurocognitive test, and you're going to be working with the student on following all the recommendations from home about cutting down the social events, following the academic recommendations, and following whatever the medical doctor says to do. there is some new guidelines now about some safe cardio activity, and that might be something that gets reintroduced and you might be involved in that. On the medical team, if you are a medical provider, you're going to be maybe the first to be the one to diagnose the concussion, to remove them from play, to be watching out for anything other than a concussion, such as a bleed. But if it's not that, then you're going to be doing a lot of education and recommendations based upon the fact that it is a concussion. Maybe rehabilitation is needed, or just education about how to support this student as they go through that 3 to 4 week process of recovery. If you are doing sideline identification, then you know that you are looking for a hit or a jolt to the body, any sign or symptom of a concussion. You are going to be more concerned about persistent vomiting, loss of consciousness, excruciating headaches, or deteriorating mental status, and those would probably require immediate transport. And then keeping your eye on this athlete even when you get back home. Don't allow them to sit in the locker room alone. Don't allow them to sit on the bus by themselves, and make sure that they are handed off to their parents. If you are in a school clinic, you maybe as a school nurse might be deciding if you think this is a concussion, and what kind of information would you send home for follow-up with a medical doctor. If most schools or many schools don't have school nurses anymore, they have health techs, and so I've worked with many schools on how to write up information for the health tech to send home. But since they are not really trained as someone to diagnose, their form may be slightly different. And I've included those here. This is one school district's notification of a suspected concussion. This is what they want their athletic trainer and their nurse to use because they feel that they have the medical background to make that determination. But if it's a health tech and they feel that that person doesn't have that kind of medical background, then this is the form they want their health techs to use, just to make the observation, to send some information home and make sure that there is follow-up with the pediatrician or the healthcare provider. So then we move on to E, which is to let the signs and symptoms educate you about recovery. We expect that there will be more intense signs and symptoms in the beginning of a concussion, and we want slow and steady progress daily, weekly, as we move forward throughout the weeks of recovery. This is what the concussion looks like on a cellular level. It has to do with the potassium and the calcium gates there. But basically, when the cellular injury happens, it renders the cell to be inefficient. And so what I always say to my students is, you are like an iPhone 6 and not an iPhone 13 when you have a concussion. You're not broken, but you have a very low battery that needs to be charged more frequently throughout the day. Or you are a car with a small gas tank, and if you drive a car with a small gas tank, you can get out of the garage, but you're just not going to cover as much territory. And that's kind of the analogy that we start to work with our teachers. So we want our students back at school, but they're not going to be able to cover as much material academically as they did before the concussion or after they're totally resolved from the concussion. The A stands for adjust and accommodate, and this is really about management. So when you look at weeks 2 and 3, who really is managing the concussion? It's going to be the family team, and it's going to be the school academic team. The family team is going to be working with their student to limit texting and limit TV and video games, but not to eliminate it completely. That would make for a very unhappy student at home. And at school, we're not going to remove all work, but we are asking teachers to consider removal of non-essential work, reduce some semi-essential work, and just limit the amount of essential work that needs to be done. So really just working with the student for the weeks 2, 3, and 4 will help to adjust and accommodate what they need at home and at school. So the home team, what we're asking them to do is to let the student rest for the first few days, and then eventually begin to add in some light mental stimulation at home, and eventually then integrate them back into school within a couple of days or maybe a week. And when you do, that you want to make sure you are telling the school that this student has a concussion, that they're going to need some return to learn supports at school, and kind of ease them back in under the care of the school nurse or the counselor, or the teachers. If it's an elementary school, then make sure the teacher knows so that they can start to work towards cutting down some of the work for the students so that they can be comfortably at school and cognitively available to learn. This is the adjust and accommodate page for the teachers. This just gives teachers some ideas on how to support a student depending on how the symptoms are manifesting throughout the day. So here are some ideas that they can pick from and go back and forth with. And then this is a page in the REAP manual that is for teachers that gives them ideas on how to adjust or accommodate, for mental fatigue, for processing speed, for trouble with memory, for those emotional outbursts, etc. A lot of the material that we do for teachers and for schools goes beyond the REAP book into the Get Schooled on Concussion materials. As an example, when we're talking with teachers, we focus on just mental fatigue, which is about symptom management, and then we focus on workload management, which is slow processing speed issues, and so that impacts workload management. And then finally on short-term memory, which to teachers impacts the student's ability to master material and to take tests and to get certain grades. So that's all we focus on when we are working with schools on the academic side, because that's really what the teacher hears. Has the student been here at school able to physically manage symptoms so they can hear instruction? Once they've heard instruction, how much work can I cut back? And then how do I hold them accountable with mastery and grades? So we won't go into a whole lot more about that. That would be a training at a different time for teachers, and we've already done one for you guys. It has been archived. But basically, we're working with teachers on trying to reduce the nice to knows, the need to knows, and just focusing on the must knows of mastery of material. This all fits within the multi-tier system of support or response to intervention that is already going on in your schools for reading disorders, behavioral disorders, and this would just be the same thing for concussion management. So if you are a teacher, you know that we already have these things in place for all students who struggle, or if you're a coach or a parent, just know that schools have these things in place to support students no matter why they are struggling at school. Okay, so going back to the REAP book, this is the page that all the athletes and all the students eventually get to, and they ask me, how do I get back to my sport? How do I get back to my life? And we have identified these 5 areas that are necessary to get to before we start moving you through the graduated return to play steps. So when the student is back to all of their pre-concussion activities at home, the chores that they were doing, the ability to hang out with parents and siblings like they were before, the ability to go to social activities and not have symptoms flare, it's not too loud, it's not too provoking of symptoms. That's one of the criteria. Back to pre-concussion home level of symptoms, not necessarily 0 because we all have some symptoms, but back to their pre-concussion level at home. And then we also want to get input from teachers. When are they back to their pre-concussion learning level? And so that would be where they are no longer having work pulled back. They are doing all the same amount of work as everybody else. They are able to do that work. They are able to manage the same amount of homework, to take tests. And if they were struggling with math before, maybe they're struggling back to that same level with math, but they are certainly not having issues related to the concussion anymore. If you're doing neurocognitive testing at your school, when is the student back to their baseline level of neurocognitive testing or back where we think they should be if they don't have a baseline? If you are checking symptoms weekly at school, either with the school nurse in the clinic or with the athletic trainer in the training room, are they back to their pre-concussion level of symptoms? And have they been discharged from any of their rehab that would be with a PT or an OT? And are they off all over-the-counter medications for treatment and symptoms of a concussion? When they hit all of these 5 criteria, and of course, if there is a medical doctor involved and the medical doctor is also taking a look at them to make sure that everything is okay there, that's when we can start moving them forward. So the REAP manual has a list of symptoms that you can use at the time of the injury. You can use it hourly, you can use it daily, you can use it weekly. And I would suggest that you want to incorporate this into your school clinic or into your school training room if you're not already doing this. And then the REAP book also has a teacher feedback form. The way I use this form is I ask my students to go around and get or collect feedback from their teachers. This is not a form that I give to teachers, and I tell the students that it is your responsibility to go around and talk to each teacher, make sure that they have a chance to answer these questions about you. Are you still giving me adjustments for my concussion, or am I just doing work like everybody else? Are you still seeing any symptoms of a concussion, like I'm asking to go to the clinic because of a headache, or I need to put my head down because I'm tired? Or do you believe that I am back to my pre-concussion learning level? Just yes or no, date it and sign it. So this is a really fast form that the student can take around. They collect the data, they bring it to me, and then I use it as one check mark on the criteria towards moving towards graduated return to play. So you can see that we are all in our different teams working to move this student closer to the point where we can eventually hand the baton back to the coach, the athletic trainer, and the healthcare provider to start the graduated return to play steps and to eventually get through those and then to reach clearance. So that's what P in REAP stands for. That is pacing. So this is a consensus decision when everybody, all the 4 teams who have been involved, believe that the student is back to where they need to be and, you know, back to their pre-concussion learning, back to their pre-concussion personality, doing chores, interacting at home, level of symptoms, then hopefully we can get them to the approval to start the graduated return to play. And as you know, as coaches and athletic trainers, these are steps that have come out of the Berlin guidelines. We'll see if those change in the 2022 Amsterdam guidelines. But right now, these have been fairly consistent that we go through these 6 different steps. So first of all, it's just doing nothing, it's just resting. And then eventually some light aerobic activity, then some eye-hand coordination, and then a non-contact workout, and then a full contact workout, and then finally normal clearance, normal gameplay. 24 hours in between each one of these steps, and if a symptom flares, you stop and go backwards. And then you start moving forward again. So if you look at your guidelines in the REAP book and also online for all of you, you can see that you follow those steps pretty much in the same way. What I really like about your guidelines is that you do specifically state in there that when a student is in session, they must be attending school full day and they must not have any classroom modifications. Otherwise, if they are still on a partial day or if they are still having work cut back from them, that would technically be considered a concussion symptom in the cognitive area. So that would mean that they're not yet ready to start their graduated return to play. And I love that about what you've put in your guidelines. And then after that, the rest of it is pretty much the same. Once you are ready to start moving forward on your steps towards clearance, then you move forward in those same steps. You don't do game participation until day 6. And so you follow these just exactly the same. What I find when I'm working with schools is that there's a lot of question with school nurses, about how do I get my non-athletes back to recess and PE and play? And because without having to follow the return to play legislation, which is required of athletes, some of our students get a concussion, they come out of PE, they come out of recess, play at recess, and then they don't go back to see a doctor for clearance to get back to all of those activities at school. So the Get Schooled on Concussions has a tip sheet that you can use if they are symptomatic, if this student is symptomatic in any way, per the parent, per the teacher, per the coach, athletic trainer, or the school nurse. Those are all those 3 scenarios on the left. Then you're not going to start graduated return to play. But if you find that everybody who knows this student says that they are asymptomatic, and they are ready to start moving towards graduated return to play, but this is a family who's choosing not to go back to a doctor and doesn't have to because it's not an athlete going back to play, then you're going to still want to give some time for a gradual return to physical activity Where that gets done is different in different places. That can be assigned to the parents to do. Sometimes people at the school are willing to do that, but not always. And so the concept is the same though. Be symptom-free and then step back in slowly through physical activity, making sure that symptoms don't flare. And then when you are done, you can then go back to your play, whether that is sports or whether that's PE or play at recess. What are the contributors that make some kids take a longer recovery than others? That would be what we call protracted recovery. And I'm sure as an athletic trainer, a school nurse, and a coach, you've seen this many times, that there's just a subset of students who just do not get better within that first month, that 28 days. And the things that tend to hold up that recovery, at least in my estimation, are three areas. One would be what I call concussion originated, meaning that this is a student who never had any eye problems, ear problems, balance problems, headaches before a concussion. And now, because of this concussion, they are having these issues, and they just probably need a little bit more time with rehabilitation. The other group that I see are what I call concussion exacerbated. These are the students who might have had a learning issue underneath, headaches, pre-existing mental health issues, pre-existing eye issues like developmental ocular motor issues. And then when the concussion happens, it just flares those things, or it exacerbates those things. And now we really have a exacerbation of a pre-existing condition that is flaring with a concussion. So in those cases, you're going to need to bring it down to what is the real problem and perhaps focus on one of those areas. And you might have to just kind of go backwards. And for a student who had vision therapy when they were 6, for example, now the concussion has sort of knocked that out of place. Well, they might need to go back and do a little bit of a booster shot with that vision therapy and then come back to the concussion therapy. And then there's a smaller percentage of kids who have some difficulty with getting through all of this. And but on the objective level, they're not showing anything that is concussion related. So it seems like they're completely resolved from their concussion, yet they're still saying that they have symptoms, they still need academic accommodations, they still don't want to go back to play. And sometimes that used to be called malingering, it's now called misattribution of symptoms. And basically in those cases, you have to dig a little deeper as to why the student or the parent is having some anxiety about them going back to full workload at school or going back to play in sports. There could be a bullying situation going on. There could be secondary gain. There could be an accident where there's a lawsuit happening, or it could be a very anxious parent who's just afraid to let the student go back to kind of the routine of school. So these are the areas that seem to hold up recovery longer than the 1 month. You can see here that those are all treated differently depending on what you decide is the underlying reason for this protracted recovery. You're going to treat that differently. If it's concussion originated, you're going to do longer rehabilitation. If it's concussion exacerbated, you're going to need to see if your concussion rehabilitation is really the key to this, or if you have anxiety that is flaring during recovery of a concussion, perhaps going back and getting a little bit of support for the anxiety might help. Because no amount of vestibular physical therapy is going to help the anxiety. So you might have to step back, treat the anxiety, and then get back into vestibular physical therapy. And if it is a misattribution of symptoms, these students who have a reason to stay out for longer, you're going to want to figure out what's going on behind that and see if you can resolve that issue. For example, if it's a bullying problem and the student doesn't want to come back to school, it's better to address that as the bullying issue rather than just have the concussion linger forever, because it's a way to keep them out of school or get them support in a way that they are not getting otherwise. And the phases of recovery, this is also from Get Schooled on Concussions. In the beginning of a concussion, we really focus on symptom management and then workload management and then mastery and grades. But as time goes on, we don't expect symptom management to be our #1 problem. We expect that symptoms eventually get under control. They're not going to be gone until we're done with a concussion, but we don't want them to be debilitating. They're probably, hopefully at that point, just annoying. And then we focus primarily on workload management. And if this goes on for months instead of weeks, we definitely don't want symptom management to be the biggest issue. We want normalization of life, figuring out how to continue to rehabilitate this, keep workload going so that we don't get a drop in grades and lose any important information for advancement of grades next year. So if you have someone who's having a protracted recovery, we do have a formula for a 504. It's based on length of time and or severity of symptoms plus need, and this is in the Get Schooled materials. And we won't go into this now because we hope that the majority of our kids go through this, but you might know as a school nurse that you are dealing with some of these students who struggle for longer. These are some of your own Arkansas resources, and this is on the back of the REAP manual for you. And this is your actual Concussion Act is on the back of your REAP manual as well. These are the many different partners who brought REAP to you in your state. And if you are looking for more information and support from them in any way, feel free to contact them and see how else they can help you with concussion management. It's really not hard, but it is complicated to do concussion management because there are so many moving parts. There are all these 4 different teams and they're equally important. They all have an important role at various times. So it takes a village to get everyone through this. These are resources that I have talked about today. They Get Schooled on concussions, the REAP concussion. And then if you are looking for resources for more moderate to severe brain injury, such as Tier 2 level or Tier 3, which is special education, the CoKidsWithBrainInjury.com is a great website that we use here in Colorado with the Colorado Department of Education. This is my information if you have any questions that you want to ask me or any resources. And then the recorded webinars that we have now done fall in these 4 areas, and you can find these at this website, arbraininjury.org, for more information. All right, I am going to open this up, stop sharing, and open this up for any questions that we might have with our time left over.
Thank you, Dr. McAvoy, for all of that great information, as always. If you do have any questions for Dr. McAvoy, please put them in the questions area of your Ascendi panel, and we can get those questions answered for her. All right, not seeing any at this time. We really appreciate everybody attending today. And again, the handouts are available for download, and they'll also be available at arbraininjury.org, as well as the recording. So we appreciate everybody, and thank you again, Dr. McAvoy. And we don't want to have to use this information, but we want to be able to have it when we do have it. Any concussions in our arena. So thank you very much, and y'all enjoy the rest of your day.
Thank you.